now, and then we'll also stream to our YouTube channel.
Thanks, Indra, for being handyman for everything tonight and sharing.
And we're just letting everyone in now.
Great.
Can I just confirm you can see the PowerPoint presentation? Is that right?
Yeah, it's a non-presenter mode.
Okay, cool.
So are we live? That is the question.
Yes, we should be live on YouTube and the Zoom meeting.
Great. Oh yeah, I've seen live on YouTube has appeared in the top right corner of my screen. So welcome everyone. Good evening to you all. Thanks so much for joining us for the second session of our Interventional Radiology Journal Club, which has been organised by the British Society of Interventional Radiology Trainees Committee in collaboration with IR Juniors. And this is a monthly event designed to try and share knowledge and promote, great, amazing and exciting IR research that's coming into the field. Now, we have two of us chairing this session today. My name is Jim. I'm based in Leeds. I'm an Interventional Radiology Fellow, and I'm also the BSIRT Chair. And we also have Indra, who is the founder of IR Juniors, who is my co-chair. Unfortunately, Dr. Shayan Patel, who actually organized and did all the hard work for this session, can't be with us for personal reasons. So, our thoughts go out to him. But, thank you, Shayan, for putting in the hard work in organizing this. So he's done all the collating of, panelists and organizing the material. So thank you very much. So today we have a very exciting topic. We're going to discuss the Fem Trial, one of the seminal papers in interventional radiology. And this is a multi-center randomized controlled trial which compares a uterine artery embolization with a myomectomy, a surgical procedure, and it looks at quality of life in women with symptomatic fibroids. We have an all-star cast, so really excited to hear from everyone. We have Dr. Drew McLean, who is an interventional radiology fellow in Southampton, who has kindly volunteered to present the study of the Fem Trial. We have Mr. Dimitrios Milikos, who is a consultant gynecologist based in Southampton, joining us. We have Dr. Lakshmi Ratnam, an interventional radiology consultant based in London at St. George's. Dr. Timothy Bryant, who is also an interventional radiology consultant who is based in Southampton. And we have Professor Teresa Caridi, who is an interventional radiologist and also director of the Division of Vascular and Interventional Radiology at the University of Alabama, Birmingham, USA, previously based at Georgetown. You may otherwise know her as the Fibroid Lady on social media for all the Twitter users out there. So again, thank you, Professor Caridi, for joining us on this meeting. We really appreciate your time. So without further ado, I will briefly talk about the two different interventions that we'll be listening to from the Fem Trial, and then I'll hand over to Drew. So what is uterine artery embolization and what is myomectomy? So next slide, please. So fibroids are abnormal proliferation of uterine smooth muscle cells. Another term for fibroids are leiomyomas, and it's a very common benign pathology of women who are in reproductive age. And it's very common, as you can see from the statistics. It affects up to 70% of Caucasian women and up to 80% of Afro-Caribbean women. Next slide, please. A large proportion of these patients do suffer symptoms related and attributable to their fibroids. And these include uterine bleeding, which can result in anemia, pain, which can be pelvic or back pain in nature, urinary frequency, pressure symptoms, so constipation. They can become subfertile, and they can struggle to conceive and to have children. And this relates and causes lots of emotional distress, including depression and anxiety. Next slide, please. So where are leiomyomas or fibroids located? Well, multiple different locations, as you can see from this diagram. They can be subserosal, they can be within the uterus wall itself, intramural, they could be submucosal, or they can be pedunculated. with this stalk-like appearance protruding outwards of the uterus or within the uterine cavity. Next slide. There are a variety of treatment options, starting from conservative medical options such as pain control. You can take the oral progesterone pill to reduce symptoms of a heavy period, which are usually worse with fibroids. You can take hormonal medication, and this is to try and shrink the fibroids as well. There are interventional radiology procedures which involve embolizing the blood vessels supplying these fibroids. You can burn these fibroids using a technique called ablation, and there are surgical techniques which involve removing the uterus as a whole or the actual fibroids selectively. Next slide. So the two different interventions we'll be hearing about in the FEMME trial are uterine artery embolization, which involves using small and a flexible tube called a catheter, which you then guide up to the uterine artery, which is the blood supply to the uterus. You then inject small particles called embolic agents into these uterine arteries, and these supply the blood and blood to the fibroid and the uterus. And the goal is to block the fibroid blood vessels, and that starves the fibroids of oxygen, and they shrink and they die that way. Myomectomy is a surgical procedure which is used to remove, again, uterine fibroids, and depending on the location of these fibroids, it can be done from inside the womb using a hysteroscope or through the abdomen using laparoscopic surgery. So that's a very short introduction as to what these interventions are. And if we could hand over to Dr. Drew McLean, who will tell us about the FEMME trial. So thanks very much, Drew, again for your time. Yeah, we can see your PowerPoint. Perfect.
Good.
You're good to go.
And you can hear me. Good start.
I can hear you perfectly, yeah.
Okay, so the FEMME study, embolization versus myomectomy, what's the best uterine sparing technique for fibroids? I'm Drew McLean. I'm an interventional radiology registrar at Southampton. And I suppose, in a way, that's a very important disclosure because I'm an interventional radiology registrar. I'm closely involved with the embolization practice at Southampton, and particularly the follow-up of patients who have fibroid embolization. And therefore, I'm massively biased because I think this is a fantastic procedure for women with fibroids. However, I have no involvement with myomectomy. And I think we have to be very honest with ourselves as interventional radiologists that we are biased when we're looking at studies like this. This is actually a recognized psychological phenomenon. I don't want to go off track here, but it's known as cognitive dissonance. And basically, if you show a group of experts a study that goes against what they believe or they want to believe, they're much more likely to find negatives with the study or with the study methodology. And I have to say this definitely affected me because I already knew what I wanted the FEMME study to show before I'd even read the paper. And initially I didn't like it. And I had to read it a few times to fully understand it and realize that actually it was me that was biased. So I'm going to try and give you as unbiased a summary of the paper as I can. Now, the reason I say this is because I think there are actually several perspectives you can take on this paper, whether you're a gynecologist or an interventional radiologist, but actually there's only one perspective that matters, and that's if you're a woman with symptomatic uterine fibroids and you want to make an informed decision about what kind of treatment you can have, and particularly if you want to keep your uterus, and particularly if you have future fertility wishes. And if that's the scenario you're in, then this is, I would say, a landmark study from that perspective. And the reason this is so important is this graph. Okay, I saw this in JVIR last year and I was shocked actually, because the red line is the laparoscopic hysterectomy rate, which is just going up and up and up. And embolization and myomectomy rates are actually going down. And I suppose the reason I found this so surprising was because if you, as a woman, you are fully informed of the risks of myomectomy, but also the long-term morbidity associations, which is alluded to in the editorial which accompanies the FEMME study, which is brilliant. And I think I would urge anybody that hasn't read it already, you should read it. And I think if you knew that, I guess I just find it surprising that so many people, over 3/4 of women, would decide to have a hysterectomy when there are such good other options. And that is why this paper, I think, is so important, and I think everybody should know about it. There are lots of things to like about this study. So this is a multi-center study. There were 29 centers in total, which I cannot imagine the logistical nightmare of trying to make sure all the data is uploaded from all those centers. I think they made real efforts to make sure that the study was reflective of real life practice. So they said, look, you can do whatever embolization technique you normally do, or you can do whatever myomectomy technique you normally do. The study was conducted by an independent clinical trials unit. And in the early phases, when I was convinced the paper was maybe biased, I even looked up and checked who was on the oversight committee, and I was pleasantly surprised. It's quite a balanced oversight committee, at least 2 interventional radiologists on that committee. And the best thing about this paper, though, is it's published in not just one of the biggest medical journals in the world, it's the highest impact factor medical journal, the New England Journal of Medicine. And for an interventional radiology study to be in there, I just think is a fantastic thing. And the final benefit I just want to raise at the start is that the outcome was this quality of life score, which is a highly validated questionnaire score. So I really don't think you could choose a better outcome than that. If you haven't read the paper in detail, don't worry, it's very simple, and I'll explain it as we go. So basically, they randomized 254 women into 2 groups, okay, into embolization group, which is, so that's supposed to be a catheter there at the top that we use for embolization. And on the other side, that's supposed to be a scalpel, which represents the myomectomy group. And they split them into 2 groups, as you would. And as I said, they looked at them at 2 years after follow-up, as well as other intervals, but 2 years was the primary endpoint. And they did the questionnaire score, with a higher score being a higher quality of life. And they said in the embolization group, it's 80. In the myomectomy group, it's 84. And this is a significant difference. They did something called an intention to treat analysis, which sounds complicated. It's actually very simple. And I'll also talk you through that briefly as well, because that is also very important to know about. And they had an 81% questionnaire return rate at 2 years, which is actually pretty good. If you think about it, 29 centers, that's not bad. The second key thing they looked at was complication rate. And actually, I still feel a little bit hard done by on this one as an interventional radiologist. And they looked at overall complication rates for both groups. Again, they used intention to treat analysis, and I'll talk about that again. And they said it was 24% in the embolization group, and it was 29% in the myomectomy group. And they said there was no significant relative risk, so the risks are similar between the 2. And the third and very important thing they looked at was fertility. So amongst other things, they looked at the pregnancy rate. And they said it was 8% in the embolization group, and it's 4% in the myomectomy group. And they said there was no significant difference. Now, this is actually a massive thing for embolization, because previously there was some ideas that this would not be a good thing for people who want to have children in the future. And I think this paper, as one of the things, has completely blown that myth out of the water. Well, I hope it has anyway. So I mentioned briefly, it was intention to treat analysis. And the alternative to this is per protocol analysis. And it's a very simple difference. Basically, you split your 2 groups. And then in the embolization group, you would hope that they will have embolization, but obviously this is real life and that's not what happens. And 80% of patients ended up having embolization, and 20% had other things. So about 11% had myomectomy, which is obviously the opposite thing of what you'd want them to have. 7% had nothing at all, and no patients had hysterectomy. So the question is, okay, which of these patients do we look at? Do we look at only the ones that had embolization, which might logically you'd think that makes sense because that's what we want to look at, or do we look at all of them together? And the medical statistics community is very clear on this. Randomized controlled trials, you look at all of them, even if that's slightly counterintuitive. And the reason for that is if you exclude those patients that have other treatments, you actually introduce way more selection bias into your study than if you'd have just looked at the embolization patients. So they did intention to treat. It's sometimes it can be a bit counterintuitive, but that was 100% the right thing to do. I've spoken with a medical statistician about this. He's pretty clear on that. Okay. Now, the numbers were slightly different for the myomectomy group, with 85% having myomectomy, 5% having embolization, a much larger proportion having hysterectomy, and less having no intervention at all. So if you're a biased intervention radiologist like I was thinking, well, hold on, you know, these are small differences between the two groups. Maybe it's just down to those ones having hysterectomy who would have a better symptom outcome. Or maybe it's just, you know, more patients had no intervention at all in the embolization group and were still followed up. Well, if you are a biased intervention radiologist, I've got some bad news for you. And they also did a per protocol analysis, which was in the supplementary material, and there's a clear difference. And I think as intervention radiologists, we have to hold our hands up and say, I think this study has demonstrated that myomectomy gives a small but statistically significant benefit. Now, the complications, as I said, I still feel a bit hard done by this. Again, they used intention to treat. So they looked at complications for not just embolization, you know, patients in the embolization group, they looked at all of them. And the other thing, they didn't grade complications. They just looked at overall percentages. Okay. So now this is what I want to show you. Okay. Again, as a biased intervention radiologist, this is the per protocol analysis. So these are all the patients that just had embolization and all the patients that just had myomectomy. So no mix-ups in the group. These are the figures. And I think this is why I feel hard done by, is because if you look at the significant perioperative complications of hematoma, major hemorrhage, blood transfusion, or infection, and this isn't including the other complication, okay, which was persistent oozing requiring ligation of the internal iliac vessels, which I'm not quite sure how that wasn't classified as major hemorrhage. You've got 0% versus 22% significant perioperative complication rate. And therefore, I do feel it's slightly misleading to say there's no significant difference in complication rate between the two treatments. And if I was a woman with uterine fibroids and I was thinking about treatments, I think to read the FEMME study abstract and say that there's no difference, I think potentially doesn't quite tell the full story. They also didn't do a relative risk calculation for the per protocol complications as they did for the intention to treat. And I just wonder, maybe there might have been a significant difference there in the complications. The third thing that they looked at, like I said, was the key thing they looked at, was fertility. And this was a really positive thing for embolization because there was a really high, a higher rate of pregnancy and a higher rate of live births in the embolization group, which is great. I did notice that there were 2 miscarriages in the group, 2%, and there were none in the myomectomy, which did make me think, worry initially. But I was going through this with my wife yesterday, and she actually pointed out that miscarriage, that's about a 22% miscarriage rate, which is completely consistent with normal pregnancy miscarriage rate. They also did the AMH, anti-Mullering hormone levels, and which is basically the best predictor of ovarian reserve, and they showed there was no difference in the 2 groups. So I think this is a brilliant thing in terms of fertility for embolization patients. 2 other graphs I wanted to show you. One was the reintervention rates, which shows that there's, you know, a clear benefit to myomectomy in not having to have interventions in the future, which I think is important to know. And I thought this was interesting. It basically has 2 simple questions. Would you have your operation again? Would you recommend your operation to a friend? And the reason I think this is a good talking point is because I often wonder, are we as intervention radiologists doing everything we can to make this a bearable experience for a woman having the procedure? Are we on top of pain relief during the procedure? Are we on top of pain relief after the procedure? Do we have the same clinical follow-up and as gynecologists do for their myomectomy patients? Because there was a slightly higher percentage of people that would recommend the operation to a friend. The other interesting thing I thought was that 3/4 of patients would recommend, would have the operation again, but even more would recommend it to a friend. So there's about 10% of the population that wouldn't be willing to have it themselves, but would happily put their friends forwards for it. So in summary, I know this isn't a complete, analysis of the paper, but I think these are the key points for me, and I wanted just to give an overall gist of what I felt about the paper. So overall, I think this is a brilliant study, and I think it's in a massive journal, and I think this is a great thing for interventional radiology. But more importantly, I think this is a landmark paper. If you're a woman with symptomatic fibroids, I think this is a fantastic thing for you. I think this study shows that fibroid embolization is a great option if you're a patient with future fertility wishes as well, which previously wasn't always thought to be the case by everybody. And as a biased interventional radiologist, my reading, if I'd have written the abstract, I would have said that myomectomy has a small but definitely statistically significant quality of life advantage and lower reintervention rates. But I would also have said that I think there's a lower rate of significant complications in fibroid embolization. Thanks for listening.
Thanks so much, Drew. That's brilliant. Thank you for putting in all that time and effort to break it all down, making it so clear with the findings, and making it really easy to understand for everyone, particularly our pre-radiology trainees out there. And I echo what Drew's mentioned. This is really a landmark paper for interventional radiology. Just to be on that platform, I think is fantastic, and just highlights the type of high quality research that we need to be focusing on. And part of the reason that we're trying to showcase some of this work is that we want to show that interventional radiology plays a part in so many different organ systems and makes a difference. But what we are lacking at times is that high quality randomized data. So thank you very much, Drew. Do we have any questions, Indra, from the audience?
Yes, we do have a couple. So if it's okay, I'll pose these to the panel and we can get your thoughts on that, if that's okay. So the first question is, did the paper discuss reasons why a patient would not wish to have the procedure herself or refer it to a friend, in particular with reference to the IR procedure arm?
No. Actually, that table I showed about refer a friend was just featured in the supplementary material. So they did make a very brief reference to it in the actual paper. I think the thing is they collected so much data, and you can't have a 20-page research article. So no, it didn't actually feature in the in the original paper.
So the next question is, so how does the Fem trial change your consenting process, if at all? So it might be useful to get both a gynecology and an interventional radiology point of view for this one. So Mr. Milagos, if we can start with a gynecology point of view.
I think it's a really good study, very clear message and results. And because we are most of the times the clinicians that we first see the patient, so we've got the advantage, or not the advantage, we have the chance of kind of guiding the patient. So it is important that actually you are not biased when you counsel the patient. So I think that's a really good pragmatic RCT that gives a clear message that, and for me, I don't think that's a matter of what is better or not. I think the main thing is that both procedures are very successful, actually, and they make a significant improvement to the symptoms. And so you need to have the confidence to discuss that with the woman in front of you and say that's a very good procedure. And certainly all that will help the counseling and the consent so that then you can sell the procedure to the patient and then get them to your IR colleagues. So I think it's it's really good. I think it will definitely help my kind of discussion with the woman.
Okay. And maybe Professor Caridi, if you'd be able to give an interventional radiology point of view as well.
Sure. First of all, thanks again for having me. I think the consenting process, I've always given a bit of a we don't, the information hasn't really changed regarding fertility in my mind, although other studies have shown a difference in fertility. The ones that I've relied most heavily on, and I think most people have, are the Mara et al. Studies. And if you look at the Mara et al. Studies, one, they looked at UAE versus myomectomy. Another, they looked at UAE versus laparoscopic uterine artery occlusion, which obviously is not a preferred method. However, if you look at both those studies, the pregnancy rate for UAE was so vastly different in studies that was done by the same author that I think the question has always been, how reliable is our data? Not to suggest the studies weren't done well or that they weren't attempted to be done well, but just, is that data really reliable? So for instance, in the study with myomectomy, the pregnancy rates for UAE were remarkably low compared to myomectomy. When you look at the study with laparoscopic uterine artery occlusion, the pregnancy rates for UAE were very similar to uterine artery occlusion, but more importantly, they were just dramatically higher than they were in the other Mara et al. Study, going from about 40% to close to 70% pregnancy rate achieved. So I think the data has always been confusing in this area. And this doesn't really change that for me. I think what I can say is that, when a woman really desires future fertility, there's two very good uterine sparing methods that can be utilized. And there's a risk with either of those that we may impact fertility. And what degree that we impact fertility, I don't know. And I don't think I know after this trial either. I would just say that they're very likely similar. And when a woman really has a terrible quality of life related to fibroids, it's really her choice whether she wants to undergo a procedure that might have some impact on her fertility or not. And I think that's really just part of the counseling and consenting process that continues for me now, that I utilized before as well.
Thank you so much for that. So one of our follow-up questions is related to that. So how would you approach the question in counseling them regarding fertility worries? But would the answer be essentially that we don't know, and it would be up to you on what you would prefer for other reasons, but in terms of fertility, we wouldn't be able to advise you on one treatment or another?
If that's coming back to me, I welcome anybody else to elaborate as well. But my answer would be exactly that. I don't think we know the full impact on fertility. There probably is some, and even though we don't see any ovarian reserve markers changed, does global embolization of the uterus have some impact on fertility? Probably so. It probably does, whether it's initial pregnancy rate or change in live birth rate. There's probably some effect. And I think also myomectomy, there's probably some effect. And so I really believe it's a woman's choice and that they should know there's potential impact. If their fibroid disease burden and symptoms and quality of life are that poor, I think it is completely up to them to move forward with a procedure as long as they know there may be some impact. And on the flip side, if their disease burden isn't terrible and they are able to wait and go ahead and finish fertility, they may wait until after that to move forward with one of these procedures.
Can I just say, make a comment on that? So I totally agree with Professor Karedi that I don't think this study really adds that much when it comes to fertility. I mean, the figures are very small. The live birth rate, which is in fact the important thing, very small numbers. We don't even know whether any of these patients had any fertility problems. Okay, so that's also an important thing when you discuss these procedures. I mean, have there been any fertility problems? Because fertility is such a complex issue. And then let alone all the other factors, you have the number of fibroids, the location of fibroids. So I agree that I don't think that this study can really answer that. And probably the most honest thing would be that we don't really know what I think it's, as far as it goes for ovarian reserve, we can be reassured, and there have been other studies and Cochrane studies that systematic reviews that haven't really shown a difference, and that's good. There is a lot of discussion about potential abnormal placentation as well after embolization, but equally that's the same thing when you've done myomectomies. So again, I don't think that you could really argue towards one or the other procedure. So I don't think I think the honest answer would be, as Professor Caridi said, we don't really know. It's on the basis of how bad are your symptoms. Can you wait? Can you not? That would be my opinion.
Okay, so thank you so much for answering that. I don't think we've got many more questions in the chat, but one question which we're kind of wondering is, how do you think this paper would be received by both patients and patient groups? So perhaps we can have Dr. Ratnam and Tim Bryant for this discussion. That's okay.
Shall I go first, Tim? Yeah, so, well, I think as Drew pointed out when he was summarizing the paper, I think people will be drawn to the headlines. And I think it's quite important when we see patients and we counsel them that we point out that even though the study has shown a significant difference between the improvement in quality of life for myomectomy versus UA, that actually what it shows more importantly is that both these procedures significantly improve quality of life for patients. And it's down to patient choice. And what it shows is that both these treatments are great options as an alternative to hysterectomy. And it comes down to patient preference, but allowing patients to make an informed choice. And I think it's important that we emphasize that in the sort of presentation of the results, that while it does show that myomectomy has a greater improvement, what it shows is that both these procedures have a marked difference from the baseline in quality of life improvement.
I think that, thanks Lakshmi, thanks Drew for that presentation. I thought it was fantastic. I mean, some of the I read through some of the stats and I don't understand. Every department needs a Drew because he's brilliant. And actually I think every patient needs a Drew as well, because I'm not sure that many patients will read that paper and fully understand the ins and outs of it, and they are likely to read editorials or breakdowns in sort of bigger sort of papers or online, or just the abstract. And the abstract, I think, as Drew said at the start, maybe is a little bit misleading, particularly in terms of complication rates. So I think it's important that patients are, yes, they will go online, they'll look at things, they'll try and sort of evaluate things themselves, but these papers are complex, and it's important that we're able to sort of give a rational and an unbiased sort of opinion to them and help them make that decision along with the gynecologists. So I think that's really important.
Could I make a comment as well? I have to give the credit to the authors, actually, that they really tried to be very unbiased on presenting the results, given that the background is, of course, you wanted to show that it's actually equivalent or even better. So I think that's really big credit to the authors. But I totally agree about the complication rate. I was actually waiting to go to the section of the complications because I thought the myomectomy would just be carnage, and it wasn't. I couldn't really understand it. So Drew, it was quite nice to outline without the intentional analysis, but of course, unfortunately, in statistics that doesn't count. But definitely would have been a very good thing to know the type of complications in terms of kind of a Clavin-Dindo classification of surgical complications, because I cannot believe that myomectomy, by definition, is an unpredictable operation, even in the best hands. It bleeds, and they have hematomas, even when they look absolutely, without any bleeding at the end of the operation. Such an unpredictable procedure. So yeah, that was my comment. I want to say about the complications that I do share the frustration. I'm equally very surprised.
Thank you. Dimitris, that makes me feel much better. I'll sleep well tonight knowing.
Maybe I'm not a good surgeon. I don't know.
Dimitris, can I ask you a question? So in the paper, there was an 82% open myomectomy rate. In your practice, what would you say the rate sort of between open, laparoscopic, and hysteroscopic myomectomy is?
Oh, that's a difficult one. I couldn't give you figures, but certainly hysteroscopic, we have a big number. I think the problem I think if you have big fibroids, multiple fibroids, and I'm a laparoscopic surgeon, okay, but I think that an open procedure is better, okay, especially if you are talking about a big, very big uterus. Now, of course, in some centers that they have very high numbers, we don't in Southampton, okay, and I think that's a mix of our population as well. And it depends on the individual surgeon. I think we're doing more laparoscopic now, but I think still, given that we tend not to remove fibroids, we don't do that many myomectomies, then the ones that we end up doing are the really big fibroids and big uterine. And certainly there is a high rate of hysterectomies as well.
One other question is that when you're doing a myomectomy, are you targeting specific fibroids? Are you taking them all out?
I would try to take all of them out. Yeah. Now, if you're doing laparoscopic, then you might be a little bit more conservative, and you will remove the biggest fibroids. It's quite difficult to find the very small ones as well. Whereas in open myomectomy, because you have the tactile kind of effect, you can feel the very small nuclei of fibroids.
So I think that is one of the other differences between embolization and myomectomy, in that you're doing a global treatment with embolization. You're treating all the fibroids, big and small. And so it would be interesting to extrapolate the findings from the Fem Trial sort of 5-10 years down the line in younger patients to see whether there's regrowth, whether there's recurrence of symptoms, and look at the results longer term.
Yeah. I don't know if you saw, Tim, in one of the supplementary tables, they divided patients into, I think, more than 7, or maybe it was more.
There was a centimetre and there was a number, wasn't there?
Yeah.
In the supplement.
And actually, I think there was very little difference. If anything, there was, I think, less difference in the smaller number of fibroids, whereas you would think actually, embolization may be better in larger number of fibroids, which I was surprised to see as well.
But I guess it's that differential, isn't it? If you're treating a young patient with a long fertile life ahead of her, and you're leaving small fibroids and not treating them, then what's the consequence of that down the line? Because we do see, I mean, you, Dimitris, you see plenty of sort of, well, hopefully not plenty, but you see patients coming back from us that come to you for treatment. We also see patients who've had myomectomies before who come back for repeat treatments and embolization with difficultly placed fibroids. So it's a consideration.
No, definitely.
I think this leads into the next question in the chat pretty well, which is asking about the location of fibroids or numbers and whether that influences the clinical recommendation for myomectomy versus UAE. And I would say there's sort of, with all of these questions, there's kind of the academic answer, and there's the gut check of whether you're the patient, how you would answer. And sometimes they're the same and sometimes they're a little bit different. But, in my practice, I talk to patients about both. And of course, I make the disclaimer right from the beginning that I'm not a surgeon. So I will tell them my general understanding of the procedure options, but certainly they need to discuss the details of myomectomy and hysterectomy with their OB-GYN. That being said, I think for me, when patients come for UAE consultation, I just try to give them some perspective on what I will actually usually accomplish in patients similar to them. So meaning I don't tell them, just like with fertility, I don't tell them whether it's the right procedure for them or not. And similarly on fibroid location, except in the cases where I'm actually worried about infection, and I'll talk about that in a moment. But otherwise, I basically tell them what to expect. What can I do for them? And what do I think on an average person with the same fibroid burden as them, what their expectations should be following the procedure. So for instance, if they have all subserosal fibroids, I'll give them some idea of what I expect the volume reduction to be. And that would be less than what I would expect an intramural fibroid to reduce by, in most cases anyway, at least in my experience. If patients have just submucosal fibroids, and particularly a large submucosal fibroid over a few centimeters, my concern there is, of course, passage and infection. And so we need to talk in those kinds of patients. I will counsel them to some degree to not have a UAE alone. And also, if they're dead set on having a UAE because they've had a myomectomy that didn't resolve their symptoms previously, they have a lot of patients who've had a hysteroscopic myomectomy where the tissue wasn't entirely removed, given, I think, some of the fluid balance issues that may be encountered during myomectomy. And so what I suggest with those patients is that if they've had for lack of a better word, failed myomectomy in terms of symptom control previously, that we may be able to do a combination procedure. And what we'll do is sometimes do an embolization to really devascularize the tissue entirely. And that way, if any tissue is left behind with a hysteroscopic myomectomy that then takes place within a week or two following embolization, at least it's devascularized tissue, and maybe they'll get a better result with the combination treatment. This is not published data or anything. It's just been an anecdotal experience. And you have to work closely in a collaborative fashion with someone that you trust in from a surgical perspective, and of course from an interventional radiology perspective. But that seems to work pretty well. And so I think it really, in terms of fibroid location and number, it really is just about setting expectations again. And there's different expectations for what you can accomplish in different locations. And that's the most important point, I think, to get across to patients.
So one of the next questions that we got was about the exclusion criteria for the trial, and they're wondering whether the supplementary material expands a bit on that, because they noted the criteria was symptomatic fibroids that could be treated with either myomectomy or UAE, and they're wondering whether that favors surgical management rather than UAE. So did the exclusion criteria kind of favor patients to one or another?
I don't think so. I mean, I think you have to have that criteria that they could have one or the other, otherwise you can't have a randomized trial. And so no, I think that's the way it has to be, unfortunately, basically. And no, they didn't, in the supplementary material, etc., they didn't really elaborate any further on that.
Okay, so next question is a bit about the technique used for embolization. So particularly for larger centers, did you notice there was a difference in operators' technique or choice of embolic agent when performing the procedure?
So they didn't actually go into detail on the technique in the paper. They just said they could use whatever they wanted as long as it was, a recognized thing. I don't know, Lakshmi, if you were involved in any more detail about, because I know, for example, like the rope study, Tim, you went to a lot of the centers and made sure they had some, a reasonable PAE technique. I don't know if any efforts like that were made with the FEMME study, and there's certainly nothing in the paper written about that, but I don't know.
No, in fact, actually, it was quite deliberate that it wasn't specified, because I think what the trial design also wanted to include, emphasize that this, this is a real world study. People do it slightly differently. They use different embolic agents, and you can't really sort of try and control that if you want to see what's happening. And most techniques are, to be honest, reasonably standard. There's some specifics which are different. For example, at our center, we all do it the same way, and we actually do bilateral embolization. So we always puncture both femoral arteries and catheterize both uterine arteries, and then we simultaneously embolize with two operators, because we're always scrubbed with a fellow. So you always have two people, so we can do one side each, but by embolizing simultaneously, we halve the procedure time and we reduce radiation dose. And I don't know if Tim, you want to talk about how you do it in Southampton?
We don't do that. We do a unilateral puncture and then tend to mostly use full French catheters. Use microcatheters when the anatomy is tricky, or when there's a tight angled origin or there's ongoing spasm. And to be honest, I think with modern equipment and low dose fluoroscopy, the doses are very, very low for embolization anyway. So we haven't gone to both sides. I think I don't know if in the trial did you have a minimum number per annum of fibroid embolizations that each study was performing? I mean, there was another study I think that they ran in Europe. Was it Hopeful, or I can't remember the name of it? That I think, because again it went for the real world situation, but it did include sort of certain centres that were just starting in their practice, and whether that skews things. And we did the same for the UK route, because PAE was really early in its infancy, and so we incorporated the learning curve in a lot of the data that came out of UK route. And I think that's a good thing, because it reflects real life. I think it can affect the outcome data that maybe you get. I mean, but again, it's real life, isn't it? So I guess you can't argue with it. But yeah, no, we don't do bilateral. We just use a single standardized technique.
Can I ask quickly, Lakshmi? So do both operators stand on the same side of the table, or do you have somebody go over the other side?
No, we both stand on the same side.
Okay. And also quickly, it mentioned there was an access artery occlusion in one patient in the study. Everywhere I've worked doesn't use closure devices. I imagine that was related to the closure device. And I wanted to ask anybody on the panel or otherwise if they routinely use closure devices for fibroid embolization.
Yeah, I'm not sure where that was. We don't even put a sheath in, actually. We just put 4 French catheters in and we press when we finish. So we don't use closure devices for the fibroid patients.
What I didn't quite understand is that access to the uterine artery or femoral access, because the femoral access is that's a reasonably significant complication for fibroid embolization.
I presume they meant femoral access.
Or could it have been radial access? I don't know. Because that would be the most typical place to get occlusion. And one comment about the infarction rates and technique is, I think I agree with everyone on the panel who's commented on real life experience in terms of utilizing that as an advantage in the trial. I think one of the challenging areas is looking at the complete infarction and near infarction rate in combination seems to be lower than in other trials that have been done for UAE, and as a combination of those two. So they were in the low 70s versus usually those two combined make up more than 80% of most trials patients results. That being said, one of the other areas that I think is confusing, just because we all practice a little differently, is MRI was done in some patients, but not all. And of course, that's going to be with any trial. But one of the difficulties is kind of knowing whether pre-procedure, if patients have some other ongoing, some other concomitant disease process like adenomyosis that might have changed the way that the technique was done. I don't know what everybody on the panel does, but most places in the US anyway will adjust their protocol for doing a UAE for adenomyosis if it's either in conjunction with fibroids or alone. And I have seen on ultrasound that often adenomyosis is not seen when there's a fibroid distortion. And so they're really hard to identify in conjunction unless it's via an MRI. Now, again, the adenomyosis data is probably not they're in depth enough to know exactly how we should be treating those patients, but most people believe in a step-up protocol of some sort. So starting at a lower a smaller particle size than you would for fibroids alone. So I guess I wonder if MRI had been used more widely, if we would just be able to rely on the data a little bit more and know whether there were other disease processes that would have affected the complete and partial devascularization rate, if we knew if adenomyosis or other was present as well.
We certainly MR all of ours that aren't claustrophobic before we do embolization. And actually, it's interestingly how often that we will do the MR. They'll have had an ultrasound before that will have shown fibroid disease, and it doesn't show the adenomyosis, or it misdiagnoses adenomyosis as fibroid. So you can get large volume focal adenomyosis, which is diagnosed as fibroids on ultrasound. So I think it probably is important even now outside the trial situation to do it, because as you do, we start smaller with embolics and work up than we would do if we were treating fibroids. So it does change our practice.
Just a quick question. Now that I have all the experts here, how do you kind of discuss with the patient coming that has this 20 or 18-week size broad fibroid uterus with well, heavy menstrual periods, but also the really bad pressure symptoms of a lump there? Because that's something that I have to say that I think, Tim, we have discussed that in the past, of that I struggle a little bit to see the clinical improvement, not the volume improvement, the clinical improvement on for the women that say, well, I've got that lump here, I feel like I'm pregnant. Yeah, I don't know, just I mean, enlighten me.
I would, if I see them in clinic and they have a very large fibroid, I would warn them that they will still have a large uterus once we've finished, and we would expect 40 to 60% volume loss, and hope that we get really good improvement in sort of menorrhagia symptoms, and do get some improvement in bulk symptoms. I think if they're very slim and have a very large fibroid that's protruding, then there's a chance that they may still need sort of further intervention afterwards, and they're aware of that when they come in to the procedure. So when they've seen us, they know that is a possibility. There are other patients who have a reasonable sized fibroid that they blame for the bulge in their tummy, which again, if you sit down, what I find is going through with the imaging is really useful, because actually it demonstrates to them exactly what's going on inside. And I think it's they find it very useful having a look at the images, equating it to what's going on. Some of them might not feel that comfortable when they find out that actually it's them, not the fibroid, that's causing the problem. But actually it's quite a rewarding experience in clinic.
Yeah, I would agree with Tim, and I take a similar approach. And again, I think I find as well showing them the images. Often like they'll say, oh, they've got this lump on the right side, and you can show them that actually there's a protuberant fibroid on that side. Or if they get bladder symptoms and they can see an image of the fibroid sitting on top of the bladder, then that makes sense to them. But again, always this sort of explanation that we don't expect that much reduction in volume. But I must say, anecdotally, again, this is not sort of proven on a study, but what I find is that patients who get significant symptom improvement in terms of menorrhagia will almost always also find that the pressure symptoms improve, even though the volumes hardly changed at all, which I find quite interesting because it's quite counterintuitive. If they're complaining of bulk or feeling that they've got a bulge, that may not go away, but the actual feeling sensation of pressure invariably improves if the other symptoms have also improved. So if they've got good results in terms of menorrhagia symptoms improvement, then they also tend to have an improvement in the pelvic pressure symptoms.
Yeah, I completely align with both Lakshmi and Tim in this. I hate to sound like I'm just reiterating the same thing, but setting the expectations is really important. And so if somebody comes in specifically for cosmetic reasons and they're describing a bulge and their reason for getting the fibroid embolization is simply to improve cosmesis, that's an entirely different conversation for me, and setting expectation that that's really not what we do with embolization. And I have the same experience as Lakshmi. The interesting thing is patients who get a 30% volume reduction, which is on very low side, but sometimes that's what we truly see, particularly with those subserosal fibroids. You know, I'll explain to them, we just aren't going to change the volume in this a whole lot. But it's interesting, their perception, even with that kind of volume reduction, their perception of their bulk symptoms is markedly reduced in majority of cases in my experience. So it's really just about the cosmesis conversation is the one that that I really emphasize that we don't do a very good job with.
Thank you all for your comments. I thought it might be good to finish with each of the panelists, just a 2 or 3 line summary of what they've taken away from the trial, or the results of this paper and how it would change your practice. So Drew, if it's okay, if you start with you.
Because my main learning point was that I'm a biased person, and I need to read every study a few times to realize that it's me and not the study. But I think it's confirmed what I know, which is fibroid embolization is a fantastic option for a woman with fibroids.
So Professor Caridi, we'll go to you next.
Yeah, I'm just appreciative of another set of data that supports some uterine sparing techniques, both fibroid embolization and myomectomy, because I think it's really just about having options for patients, and the details of the paper, you know, you just have to read beyond the initial headline and really get to know the details. And I'll use my line that we use in our commentary, which is essentially UAE and myomectomy for me are more alike than they are different in many ways.
Thank you. Mr. Milikos, from you.
It's a very good study. I think it gives the evidence that both procedures are very good. They have a significant improvement to symptoms, so it gives more options because culturally some women will want to avoid surgery. So it's fantastic to be able to counsel them that there is a very good option. I would be very cautious to use the complication figures of that because I think definitely surgery has more complications, okay, even in the best hands. And as we discussed about the fertility, I think it still is an unknown territory. So, but a really brilliant study, I think it's very good.
Dr. Ratnam, from you.
I think it just adds to the body of evidence. It's really important in interventional radiology that we have high quality evidence. So I think that's really great that this paper's been published. And I think it's about giving patients choices and giving them the information they need to make those choices. And the more data we have, the better. And actually, just on the fertility option as well, I often refer them. There's a joint document between the Royal College of Obs and Gynae and Royal College of Radiologists discussing fertility and treatment options, and I often just refer them to you just Google it and you can find the right section, and you just tell them to go in, read it, and it pretty much says what we've all been saying, which is that there should be nothing stopping you, nothing against UAE. We don't have strong evidence either way, but this is the evidence that we have. But this is a document that's issued by both the Royal Colleges jointly, and it's I think a good starting point for a lot of patients because they look on the internet, it's very confusing. There's a lot of things out there, and not all of it's high quality, obviously. So I think it helps.
And Dr. Bryant, from you.
I second everything that everyone else has said. I'm thankful for Drew for being able to interpret it for us and break it down so nicely. I think it's fantastic that we've got minimally invasive techniques, myomectomy, fibroid embolization on a global stage, being published in the New England Journal of Medicine. I mean, that's a fantastic kudos for the authors and the trial. It's brilliant. We've got the likes of Kamala Harris, who's got symptomatic fibroids and has had embolization. Donald Trump's wife, who's had embolization for her AML. So IR is out there, and it's important that we do continue to provide the evidence for everything we do. And things like this, working in combination with our clinical colleagues, are great, and we should do more of it.
Fantastic. Thank you very much. So final words, basically to thank all our panelists. Really appreciate everyone's time. Thank you again, Drew. One of the take-home messages for me was everyone needs a Drew in their life. And if only we could keep Drew every month to present all these papers, I think we'd all learn so much. But, you know, really appreciate everyone's time. And thank you, Professor Creedy, for joining us all the way from Florida and the US. Everyone stay safe. Please fill out your feedback forms. This is really useful. We're in the learning stages to know how we can make this better for you. We have another session in a month's time, going to the opposite end of the body, looking at radiation risks for interventional radiologists and brain radiation risk particularly. So that will be definitely an insightful session as well. But everyone stay safe and, you know, see you in a month's time. Thank you.
Great. Well done, guys. Thanks for organizing.
Thanks, everyone.
Thank you.
Take care. Thank you.
Bye-bye. Take care.
Bye.
Bye.